Dear students, the theme of lecture today, that is the clinical and pharmacological characteristic of drugs affect the digestive tract's motor function. That is the lecture plan. Cholinergic agents, laxatives, antidiuretical agents, drug used in the treatments of the irritable bowel syndrome, and antiemetic agent. Some words about the gastrointestinal motility stimulation and mechanism of working this drug. Drugs that selectively stimulate gastrointestinal motility prokinetics have significant potential clinical benefits. Drugs that increase lower esophageal sphincter pressure may be useful when the patient has a gastroesophageal reflux disease. Drugs that improve gastric emptying may be useful in gastric paralysis and the delayed gastric emptying after surgery. Drugs that stimulate the small intestine are useful in postoperative ileus and chronic intestinal obstruction. Finally, drugs that facilitate transit through the colon may be useful in the treatments of constipation. Physiology of enteric nervous systems. The intestinal nervous systems consist mainly of the interconnected network of ganglion cells and nerve fibers in the submucosal, submusical plexus, and between the circular and longitudinal muscle layers. This network gives rise to nerve fibers connection the mucosa to the muscles. External sympathetic and parasympathetic tonic nervous project to the submucoidal layers and enteric plexus, but the enteric nervous systems can independently regulate gastrointestinal motility and secretion. Cholinergic agonists such as beta-nihol stimulate the muscarinic M3 receptors in muscle cells and synapse of the enteric plexus. In the past, beta-nihol has been used to treat the GERD and gastric paralysis. With the advent of the multiple actions cholinergic drugs and less toxic agent and has become rarely used. Neostigmine and acetylcholinesterase inhibitors may promote evacuations of gastric, small, and large intestinal content. For example, that is the beta-nihol chloride tablets, which we can use, and neostigmine for injections for our patient. Metoclopramide and domperidone. Metoclopramide and domperidone are dopamine D2 receptor antagonists. In the gastrointestinal tract, activations of dopamine receptors inhibits cholinergic stimulations of smooth muscle and blockage of the actions of the THU to be the primary prokinetic mechanism of actions of these drugs. These drugs increase the amplitude of esophageal peristaltics, increase the pressure of the lower esophageal sphincters, and promote gastric emptying, but don't affect the motility of the small and large intestine. Metoclopramide and domperidone also block dopamine D2 receptors in the chemoreceptors trigger zone of the medulla oblongata, exerting potent anti-nausea and anti-emetic effects. Metoclopramide 10 milligrams tablets, and for example, the domperidone 10 tablets too. Clinical applications. Gastroesophageal reflux disease, metoclopramide is available for clinic use, and domperidone is available in many other countries. These drugs are sometimes used to treat sympathetic GERD, but are not effective in patients with the erosive esophagitis, because secretagogue inhibitors are more effective and safer in treating of the heartburn. Motility improving drugs are mostly used in combinations with the secretagogue inhibitors in patients with the reflux and intra-table of the heartburn. Gastric emptying disorders. These agents are commonly used in the treating of patients with the delayed gastric emptying due to the postoperative disorders, for example, phagotomy, gastrectomy, and diabetic gastric insufficiency paralysis. That is the problems of the parasympathetic tonic nervous systems in very many patients with the diabetes mellitus type 2. Metoclopramide is sometimes administered to hospitalized patients to facilitate insertions of the nasoenteric feeding tube from the stomach into the duodenum. 3, that is the non-ulcer dyspepsia. These drugs cause symptomatic improvement in a small number of patients with the chronic dyspepsia. The most common side effects of the metoclopramide are disorders of the central nervous systems. Restlessness, somnolence, insomnia, anxiety, and agitations occur in the 10–20%, especially in the elderly. Extrapyramidal effect, dystonia, akathisia, and Parkinson-like symptoms due to the central blockage of dopamine receptors occur equally maybe 25% of patients on high dose and in the 5% of the patients on long-term treatment. Patients taking the metoclopramide long-term sometimes develop irreversible tardive dyskinesia. For this reason, long-time use of this drug should be avoided unless absolutely necessary, especially in the elderly. Increased prolactin level caused by both metoclopramide and domperidone may lead to the development of the galactorrhea, gynecomastia, impotence, and menstrual irregularities. High-level concentrations of the prolactin, very dangerous symptoms. When we see the symptoms of the gynecomastia in men, we must check maybe this patient has the adenoma of the hypophysis. But if these patients use these drugs, the source of potential serious problems maybe these drugs, iatrogenia. Sometimes we use microlide antibiotics, very interesting fact. For example, of the erythromycin intravenous form. Microlide antibiotics such as erythromycin directly stimulate motilin receptors on gastrointestinal smooth muscles and promote the expressions of migratory motor complexes. Intravenous erythromycin is effective in some patients with the gastroparesis, but resistance develops rapidly. It will be used in patients with the acute upper gastrointestinal bleeding to facilitate evacuations of gastric content before endoscopy. You must remember, please, in CROC 2, we can find the information, the erythromycin, that is the very power inhibitors of the CYP3A4, and these drugs can depress of the activity of the enzymes CYP3A4, and this way of increasing of the concentrations of the substrate of these isoenzymes, of the cytochrome oxidase P450. Laxatives. The vast majority of the patients don't need laxatives, but a significant proportion of the population have prescribed them. For most people, occasional constipations is best prevented by a high-fiber diet, adequate fluid intake, regular excursions, and listening to the call of nature. Patients who don't respond to dietary changes of the supplementals should be medically evaluated before the embarking on long-term treatments with laxatives. Bulk-acting laxatives. Volumetric laxatives are not digestible hydrophilic colloids that absorb water to form a voluminous softening gel that stretches and the colon and promotes peristaltisis. Common preparations include natural plant products, psyllium, methylcellulose, and synthetic fiber, polycarbophilus. When plant fiber are digested by bacteria in the colon, abdominal bloating and flatulence may increase. Stool surfactant. Soften stools and promote the passage of water and lipids. They administered orally or rectally. Common preparations include docusate and glycerin suppositories. For hospitalized patients, docusate is usually prescribed to prevent constipations and reduce straining. Mineral oil is a clear, viscose oil that lubricates the stools and slows the absorption of water from the stool. It is used to prevent and treat stool obstructions in young children and debilitated adults. It cannot be taken by mouth, but can be mixed with the juice. Aspirations may cause severe lipid pneumonia. Prolonged use may impair absorptions of fat-soluble vitamins A, D, E, K. The symptoms of the deficits of these vitamins. For example, the deficits of the vitamin A, retinol acetate, the patient has the problems with the vision. The D, the results of the deficiency of status of this vitamin, that is results osteoporosis. If that is the problems with the vitamin E, tocopherol acetate, the patient has the problems with the skin. And if the patient has the deficiency status of the K vitamin, we saw the symptoms of the hemorrhagic disorders, hypocoagulation. Osmotic, next group, osmotic laxatives. The colon cannot concentrate of the dilute fecal fluid. Fecal water is the isotonic throughout the colon. Osmotic laxatives are soluble but not absorbable compounds that inevitably increase the amount of fecal fluid therapy, increasing the fluidity of the stool. For example, Miralax. Non-absorbable sugar or salt. There is used to treat acute constipations or prevent chronic constipations. Magnesium hydroxide, milk of magnesia, is a common use osmotic laxative. It should not be used long-term in patients with the renal insufficiency because that is the risk of the hypermagnesemia. Sorbitol and lactulase are not absorbable sugar that can be used to prevent of the treat chronic constipations. These sugars are metabolized of Escherichia coli and cause severe flatulence and cramping. High dose of the osmotically active drugs results in rapid bowel emptying during the 1 to 3 hours. The rapid movement of water into the distal small and large intestine produce large amount the liquid feces flow following the by bowel emptying. Classic variant magnesium of the hydroxide, really very useful in real clinical practice. This includes citrate, magnesium sulfate, and patent combinations of magnesium oxide, sodium picosulfate, and citrate. For example, that is the Prepopic. When taking these drugs, it's very important to increase oral fluids and maintain adequate hydrations to compensate for fluid loss with feces. Sodium phosphatase is also available to the prescriptions in tablet form, but the use less frequently because of the risk of the hyperphosphatemia, hypocalcemia, hypernatremia, and hypokalemia. There is a serious problems for the cardiac patients. These electrolyte disturbances are not critically significant in most patients, but may be leading to the development of the cardiac arrhythmias and acute renal failure due to the tubular depositions of calcium phosphate. Sodium phosphate preparations should be not used in form of elderly patients, patients with the renal insufficiency, patients with the severe cardiac disease, or in the patients unable to maintain adequate hydrations when the preparations are administered rectally. For example, patients with the diabetes mellitus. It is the form of the sodium picosulfate, magnesium oxide, and anhydrous citric acid, the name Prepopic. Balanced the polyethylene glycol. Flushing solutions contain the polyethylene glycol are used only for complete colon lavage, for example, prior to the gastrointestinal endoscopy. This isotonic balanced solutions is an inert, non-absorbable, osmotically active sugar with the sodium sulfate, sodium chloride, sodium bicarbonate, and potassium chloride. The solutions is formulated so that significant fluid and electrolyte shifts in the vascular systems don't occur. Therefore, it is safe for all patients. For optimal bowel cleansing, it is necessary to take 1-2 liters of the solutions quickly in the evening before the procedure, and again 4-6 hours before the procedure. For the treatments and preventions of the chronic constipations, this polyethylene glycol powder can be mixed with the water or juice. Unlike sorbitol and lactulase, these drugs does not cause severe cramping and flatulence. A classic variant of the polyethylene glycol powered for the solutions, osmotic laxative. And for example, if the patient has the intoxication, we don't prescribe, we don't prescribe the laxative lipid soluble. Why? Because the lipid soluble laxative increase of the process of the absorption of the toxin to the blood. In these situations, we like to prescribe osmotic laxative. These drugs provide a moving the water and toxin to the stool, to the feces, and removing from the organism. Stimulant laxatives. Stimulant laxative induce bowel emptying through a number of the mechanisms not fully understood. These mechanisms include direct stimulations of the enteric nervous systems, electrolyte and fluid secretions in the colon. For example, there have been concerns that prolonged phlebotomist use may lead to the dependence and disruptions of the enteric plexus, results of the atonia and dilatations of the colon. Anthrachinone derivatives, aloe, senna, and cascara occur naturally in plants. These laxatives are purely absorbed and after hydrolysis in the colon cause bowel emptying with the usually 12 hours when taken orally and 2 hours when administered rectally. Chronic use results in a characteristic brown pigmentations of the colon known as the colon melanosis. Usually the colonoscopist verify these side effects. There is some concern that these drugs are the carcinogenic, and epidemiological studies have shown unknown associations with the colorectal cancer. Senna, classic variant of the natural laxative drugs. Diphenylmethanione derivatives, bisacodil, very popular drugs for the laxative effect, is available as tablets and suppositories for the treatments of the acute and chronic constipations. It is also used in the combinations with the PEG polyethylene glycol solutions to flush the colon before the colonoscopy. When taken orally, defecations occur after the 6-10 hours, and when taken rectally, after the 30-60 minutes. Minor systematic absorptions and safety in acute and the prolonged use. The bisacodil form very popular in real clinical practice. Activators of the chloride secretions, lubiprostone and as a prostanoic acid derivatives used for the treatments of the chronic constipations and dominant constipations in the irritable bowel syndrome. Lubiprostone belongs to the type 2 chloride channels. It acts by stimulations the type 2 chloride channel. This increases the secretions of chloride-containing fluids in the intestinum, stimulation bowel motility, and the shortening bowel transit time. Maybe in 50%, half of all patients, bowel emptying occurs within the 24 hours after the single dose of the drugs. For the treatments of the chronic constipations, it is recommended to take 24 microgram orally twice a day. The effectiveness of these drugs does not seem to decrease with the prolonged administration. That is the lubiprostone in gelatin capsules, 24 milligram. Activators of chloride secretions, linaclotide and preaconazole, are short amino acid peptide with the low absorption rates that act by binding to gyelinide cyclase on the luminal surface. Therapy stimulations intestinal chloride secretions by differential mechanism. As a result, intracellular and extracellular cyclic guanosine monophosphate level are increased, and the cystic fibrosis transmembrane conduction regulator is activated, leading to abundant chloride secretions and the facilitation intestinal transit. Both drugs are approved for the treatments of the chronic constipations, linaclotide, that is the 145 microgram orally once daily, and preaconazole 3 milligram orally once daily. And linaclotide is also approved for the treatment of the irritable bowel syndrome with the constipations, 290 microgram orally once daily. We see linaclotide, 290 microgram in capsules. We saw the plecanatide, 3 milligram in tablets. Activators of chloride secretions. These drugs usually cause an increase in the frequency of the bowel emptying by an average of the 1 to 2 times per week during the first week of treatment. When treatment is discontinued, the frequency of the defecations return to the normal within a week. The most common side effect of the diarrhea occurring in up to 20% of patients, with the severe diarrhea occurring in the 2%. Absorptions of these drugs at standard dose is negligible. Both drugs are contraindicated in pediatric patients because increased mortality from dehydrations and juvenile mice has been reported. Acute and chronic opioid therapy can cause constipations by reductions in intestinal motility, resulting in the prolonged transit time and increasing fetal water absorption. Postoperative opioid use for pain relief and as well as oral opioid therapy may also increase the durations of the postoperative ileus. These effects are mainly mediated by intestinal mu-P opioid receptors. Two selective P-opioid receptors antagonists, methylnaltrexone bromide and alvipoman, are commercially available. For example, that is the methylnaltrexone bromide, Relistor, and alvipoman capsules, 12 milligram. Methylnaltrexone is approved for the treatment of the opioid-induced constipation in patients receiving palliative care for the advanced disease who respond inadequately to the other medications administered to days by subcutaneous injections, and is also approved for the treatment of opioid-induced constipations in patients with the advanced disease who responds inadequately to other medications. Alvipoman is approved for short-term use to reduce the durations of postoperative ileus in hospitalized patients who have undergone resections of the small or large intestine. Alvipoman 12 milligram capsules should be taken orally 5 hours before surgery and twice daily after the surgery until bowel functions is restored, but not more than 7 days. Due to the potential for cardiovascular toxicity, the use of alvipoman in hospitalized patients is currently limited to the short-term administration. New group, that is the serotonin 5-HT2 receptors agonists. Stimulations of the 5-HT2 receptors of the presynaptic terminals of the submucosal internal primary efferent promotes the release of the neurotransmitters such as the calcitonin gene peptide and stimulates secondary enteric neurons, which promotes peristaltic reflex. These enteric neurons stimulates proximal intestinal contraction and distal intestinal reflection. Tegaserate is a partial serotonin 5-HT4 agonist with a high affinity for these receptors, but weak binding to the 5-HT3 and dopamine receptors. Tegaserate was approved for the treatments of the patients with the chronic constipations and constipations predominant is irritable bowel syndrome. Classic variant of the tegaserate 6 milligram tablets, Zelnorm. Antidiuretical agent. Antidiarrheal agent can be used safely in patients with mild or moderate acute diarrhea. However, they should be not used in patients with the bloody diarrhea, fever, or systematic toxicity because of this risk of the worsening of the underlying disease. Why? What is it, the diarrhea, if the patient has the colon infection? That is the mechanism of the evacuations of this bacteria and toxin. If you will stopping of this process, we can provocate of the sepsis, septicemia, septicemia, shock, bacterial shock for these patients. That's why the absolutely contraindications, the symptoms of the bacterial or viral disorders in the colon. Their use should be discontinued in the patients with the worsening diarrhea despite treatments. Antidiarrheal drugs are also used to manage chronic diarrhea caused by inflammatory bowel disease. Opioid agonist. As mentioned above, opioids have significant effect in the constipations by depressing presynaptic cholinergic innervations of submucosal of mesenteric plexus. Opioid increase colon segmental activity, transit time, and fecal water absorption. Opioid also decrease the colonic motor reflex and gastric relaxations reflex. All opioids have antidiuretical effect, but the effect on the central nervous systems and potentials for the addictions limit are usefulness of most opioids. Loperamide is the one of the counter opioid agonist that does not cross the blood-brain barrier, has not analgesic effect, and is not addictive. Tolerance to long-term use has not been reported. The usual dose is 2 mg 1 to the 4 times daily. Difenoxylide is a prescription opioid agonist and has not analgesic effect as standard dose. But at high dose, it acts on the central nervous systems, and prolonged use can be lead to opioid dependence. Commercial preparats usually contain a small amount of the atropine to prevent overdose. The anticholinergic actions of the atropine, atropine sulfate, may contribute to its antidiuretical action. Well, for example, that is the loperamide, 2 mg antidiuretical drugs, Imodium. And for example, difenoxylide hydrochloride 2.5 mg plus atropine sulfate 0.0 to 25 mg. Difenoxylide tablet therapy. Elyxadrin as a prescription opioid agonist with the high affinity for mu receptors. When taken orally, elyxadrin binds to the opioid receptors in the intestine, slowing colonic transit and increasing fecal water absorptions. Elyxadoline is approved for the treatment of the patients with irritable bowel syndromes in whom diarrhea is the predominant symptoms at dose the 75-100 mg twice daily. In 2 randomized placebo-controlled trials, taken 100 mg of the elyxadoline twice daily significantly improved abdominal pain and diarrhea in 30% of patients compared to the 60% of patients taking placebo. Constipations occur in 8% of patients. Elyxadoline, 100 mg in tablets, for example, Elyxan. Abdominal pain, pancreatitis, and or spasm of the impaired the sphincters with the elevations of the pancreatic of liver enzymes may occur in approximately 1% of patients. Elyxadoline should be not used in patients with a history of the pancreatitis, alcoholism, no sphincters of the OD disease. The drug should be used with caution in patients who have undergone cholecystectomia, as the risk of the complications associated with the spasm of the sphincter OD is up to 5%. For patients with the history of the cholecystectomia, must to moderate liver disease and adverse reactions when taken in high dose elyxadrin, 75% 2 times per day is recommended. Conjugate by salt are usually absorbed in the terminal ileum, colloidal bismuth compounds. Disease of the terminal ileum of surgical resections might be caused malabsorptions of the bile salts, results of the secretory colonic diarrhea. The cholestyramine, cholesterol, or cholecylamine can reduce diarrhea caused by excess fecal bile acid. They are available as a powdered and tablets and are taken there 3 times a day before meal. Side effects include abdominal bloating, flatness, constipations, and fecal discharge. In patients with a reduced pool of circulation's bile acid, further the removal of the bile acids may exacerbate and malabsorption. Cholestyramine for oral suspension, 4 grams for treatments of our patient. Cholestatine, cholestipol, 5 grams for prescriptions for our patients. Octreotide, very interesting drugs and very interesting indications for using of these drugs. Somatostatin, that is the 4 amino acid peptide release in the gastrointestinal tract and pancreas from pancreas cells to D cells and enteric nerves and from the hypothalamus. Somatostatin is an important regulatory peptide with a number of the physiological action. What functions of this peptide? Inhibits the secretions of many hormones and transmitters, including gastrin, cholecystokinin, glucagon, growth hormone, insulin, secretin, pancreatic polypeptide, vasoactin, enteric peptide, and PH2. Decreasing intestinal fluid secretions and pancreatic secretions slows gastrointestinal motility and inhibits gallbladder contraction. Reduce portal and splenic blood flow. Inhibits secretions of the anterior lobe hormones in the pituitary glands in hypophysis. Octreotide, 30 milligrams for intramuscular injection. The clinical usefulness of the somatostatin is limited by its short time life, 3 minutes, when administered intravenously. Octreotide is a synthetic octapeptide with a similar effect as a somatostatin. It was a serum half-time, 1.5 hours, when administered intravenously. It can also be administered by subcutaneous injection, in which case the durations of the action 6 to 12 hours. A longer actions depot preparations is also available for the intramuscular injections once a month. Examples of the clinical applications of the somatostatin: inhibitions of the actions of the endocrine tumor, 2 neuroendocrine tumors of the gastrointestinal tract, carcinoid and lipoma, cause secretory diarrhea and systematic symptoms such as a facial hyperemia and dyspnea. Next, other causes of the diarrhea. Octreotide inhibits intestinal secretions and has the dose-dependent effect in the intestinal motility. Low dose, 50 microgram, stimulate motility, while high dose, maybe 100, 250 micrograms subcutaneously, inhibit it. In high dose, octreotide is effective in the treatments of the vagotomy-induced diarrhea, dumping syndromes, short bowel syndromes, and AIDS. At low dose, 50 micrograms subcutaneously, octreotide is the use of the stimulate small intestinal motility in patients with the intestinal pseudo-obstructions caused by bacterial overgrowth of the small intestinum or sclerodermia, autoimmune disease. Other the uses, the octreotide inhibits pancreatic secretions and may be useful in the patients in the pancreatic fistulas. Octreotide may also be used for the gastrointestinal bleeding. Disturbance of the pancreatic secretions may cause the deficiency of the fat-soluble vitamins. Violations of the gastrointestinal motility may cause nausea, abdominal pain, flatness, and diarrhea. Due to suppressions of gallbladder's contractility and the alterations of fat absorptions, long-term use of octreotide leads to formations of sedimentary gallstone in more than 50% of patients, but acute cholecystitis is rare. Octreotide alters the balance of the insulin, glucagon, and growth factor, so hyperglycemia, or less commonly, hypoglycemia, usually mild may occur. Prolonged treatments with the octreotide can lead to the hypothyroidism. Octreotide may also cause bradycardia. Drug use for treatments of the irritable bowel syndrome. This disease, that is the idiopathic chronic recurrent disorders characterized by abdominal discomfort, pain, distensions, bloating, cramping, associated with the change in the bowel habits, diarrhea, constipations, or both. Patients may experience changes in the frequency of the constantly of the defecations during the episode of abdominal pain or discomfort. Low dose of the tricycle antidepressant we prescribe for the patients with this disease, amitriptyline of diazepam, are useful for chronic abdominal pain. At these doses, maybe that is when the patient has the psychosomatic disorders, these treatments provide the excellent results for these patients. At this dose, these drugs don't affect mood, but may alter central processing of visceral emotion information. Anticholinergic effect of these drugs also affect gastrointestinal motility and secretions, reductions the frequency and fluidity to the stools. Finally, the tricyclic antidepressant, for example, amitriptyline, can alter receptors for the enteric neurotransmitters such as serotonin, affecting the visceral efferent sensitivity. Amitriptyline classic drugs for these treatments and diazepam hydrochloride, amitriptyline, which is the 10 milligram in 1 tablet, for example, and diazepam 75 milligram in 1 tablet. Antispasmodic, anticholinergic drugs. Some drugs are advertised as relieving abdominal pain and discomfort through their antispasmodic action. However, spasm of the small and large intestine is not known to be an important cause of symptoms of the patients with the irritable bowel syndrome. Antispasmodics act mainly through anticholinergic effect. Commonly used drugs in the class include the dicyclomine and hyoscyamin. These drugs inhibit muscarinic receptors in the enteric plexus and smooth muscle. The efficiency of the aspasmodic drugs for this relief in the abdominal symptoms has never been conclusively demonstrated. In low dose, the effect of the autonomic nervous systems is minimal. Serotonin receptors antagonism 5-HT3. Gastrointestinal receptors activate visceral pain sensitivity via external sensory neurons traveling from the gastrointestinal tracts to the spinal cord and central nervous systems. Inhibitors of the gastrointestinal efferents 5-HT3 receptors may be reduced unpleasant visceral efferent sensations such as nausea, abdominal bloating, and pain. Allocetrone is a 5-HT3 antagonist and is approved for the treatments of the patients with severe irritable bowel syndrome with diarrhea. 4 other 5-HT3 antagonists, ondansetron, granisetron, dolasetron, and palonosetron, are approved for the prevention of the treatments of the nausea and vomiting, but the efficacy in the treatments of the IBC has not been established. Allocetrone hydrochloride, for example, dose 0.5 milligram or 1 milligram allocetrone hydrochloride tablet therapy. Allocetrone is very potent and effective, selective of 5-HT3 receptors antagonism. It is rapidly absorbed from the gastrointestinal tract, has a bioavailability maybe 50–60% in plasma, and half-time of the 1.5 hours, but has a much longer durations of action. It undergoes extensive hepatic metabolism involving cytochrome P450, and most metabolites are excreted by the kidneys. Allocetrone being the 5-HT3 receptors with the greater affinity than other 5-HT3 antagonists and dissociate more slowly from the 5-HT3 receptors. Clinical applications. Allocetrons is approved for the treatment of the women with the severe irritable bowel syndromes, in which diarrhea is the predominant symptom. The drug's efficiency in men has not been established. A dose of once or twice daily reduce the lower abdominal pain, cramping, urgency, and diarrhea associated with the IBS. Approximately maybe 50–60% of patients reported that allocetron provided adequate relief of the patients at the discomfort compared with the 30–40% of the patients receiving placebo. In contrast to the excellent safety profile of the 5-HT3 receptors antagonism, allocetrons is associated with the rare but serious gastrointestinal toxicities. Constipations occur in the 30% of patients with the irritable bowel syndrome, with the predominant diarrhea, and requires the discontinuations of the drugs in the 10%. Severe complications of the constipations require hospitalizations or surgery occur in 1 of 1,000 patients. Episodes of ischemic colitis, in some cases fatal, have been reported in 3 patients per 1,000. Chloride channel activators is mentioned above the lubiprostone as a prostanoid acid derivative and stimulates type 2 chloride channels in the small intestine. Lubiprostone is approved for the treatment of the women with the irritable bowel syndrome, whose predominant symptoms is constipations. Its efficiency for men with the IBS has not been proven. The approved dose for the treatments of the IBS is the 8 microgram twice daily, 24 microgram twice daily for chronic constipation. In clinical trial, lubiprostone provided only 8% clinical benefit compared to the placebo. Lubiprostone is a pregnancy category C, so its use in women of childbearing should be avoided. Lubiprostone, 25 microgram in 1 tablets. Linaclotide is a guanylate cyclase agonist that activates the enzymes in the small intestine and promotes chloride-rich intestinal secretions. It is approved for the treatments of the IBS with the constipations in adults at an authorized dose on the 290 microgram once daily. In the clinical trials, up to the 25% of the patients receiving linaclotide demonstrate significant clinical improvement compared to the patients receiving placebo. Linaclotide is category C in pregnancy and is contraindicated in pediatric patients. Linaclotide, Linzess, 145 microgram in 1 capsules. Antiemetic drugs. Nausea and vomiting can be manifestations of the variety of the conditions, including adverse drug effects, systematic disease of infections, pregnancy, vestibular dysfunction, central nervous system infections, or hypertension, peritonitis, hepatobiliary disorders, radiations of the chemotherapy, gastrointestinal obstructions, movement disorders, or infections. Practically, the brainstem vomiting centers is a loosely organized neural area in the reticular formations of the lateral medulla oblongata that coordinate complex gagging the behavior of the through interactions with the neural network of the cranial nerves. And the solitary bindle nuclear control and the respiratory, salivatory, and vasomotor centers. Clinical uses. Clinical indications of these drugs, such as the chemotherapy, induced nausea and vomiting. 5-HT3 receptors antagonists are the main drugs used to prevent acute nausea and vomiting caused by chemotherapy. When used alone, these drugs are ineffective or ineffective in the prevention, delayed nausea and vomiting. These drugs are most effective when administered as a single intravenous dose, or, for example, ondansetron 8 milligram, granisetron 1 milligram, or dolasetron 100 milligram, or palonosetron 0.25 milligram 30 minutes before chemotherapy. Scheme of the ondansetron 8 milligram twice daily, of 24 milligram once daily, granisetron 2 milligram, and dolasetron 100 milligram as a single oral dose 1 hour before chemotherapy may be equally effective. Although the 5-HT3 receptors antagonists are effective as a single agent for the prevention of chemotherapy-induced nausea and vomiting. Postoperative, what another indications for using of these drugs, postoperative and post-radiation nausea and vomiting. These drugs used for the preventions or treatments of the postoperative nausea and vomiting. Maybe these drugs, this group of the drugs, are also effective for the prevention of the treatments of nausea and vomiting in patients undergoing whole body or abdominal radiotherapy. This group are well-tolerated drugs and have an excellent safety profile. The most commonly reported side effects are headache, dizziness, sometimes constipations. All 4 drugs cause as a small but statistically significant prolongations of the QT interval. Most pronounced this dolasetron. That is the very dangerous for the patients with the cardiovascular diseases, because that is the practically pro-arrhythmic effect of these drugs. And these situations sometimes need the decreasing of the dose, sometimes stopping of using of these drugs. Next group, corticosteroid therapy, dexamethasone or methylprednisolone have antiemetic effect, but the basic of these actions is unclear. These appear to the potentials, the efficiency of the 5-HT3 receptors antagonist in preventing acute and delaying nausea and vomiting in patients receiving moderate or highly emetogenic chemotherapy. Dexamethasone. Neurokinin, newest maybe group of drugs, that is the neurokinin receptors antagonist. Neurokinin receptor antagonists have an antiemetic effect by actions through central posterior blockage. Apparent, the aprepitant, netopitant, and rolapitant, all oral, are highly selective NK1 receptors antagonists that cross the blood-brain barrier and occupy NK receptors in the brain. They have no affinity for serotonin, dopamine of corticosteroid receptors. Netopitant 300 milligram is available only in combinations with the palonosetron 0.5 milligram. Fosaprepitant is administered intravenously and converted to the aprepitant within the 30 minutes of infusion. For example, aprepitant in capsules. Netopitant and palonosetron in 1 capsules, 300 milligram and 0.5 milligram of palonosetron. Akinzeo. Rolapitant tablets, 90 milligram. Tablets therapy, 90 milligram. Pharmacokinetic, the oral bioavailability of aprepitant may be 65%, and its serum half-time is 12 hours. Netopitant and rolapitant have longer half-lives, 90 and 180 hours respectively, and can be administered as the single dose. All 3 drugs are metabolized in the liver, mainly via the CYP3A4 pathway. Clinical applications. NK receptor antagonists are used in combinations with the 5-823 receptors antagonists and corticosteroid therapy to prevent acute and delayed nausea and vomiting caused by highly emetogenic chemotherapeutic regimes. Prevents acute emesis maybe in 90% of patients, compared with the less than 70% of patients without this antagonist. Prevent delay emesis in the more than 70% of the patients receiving the combination therapy compared with the 50% of patients treated without the NK antagonist. Practically, oral NK receptor antagonist may be administered as follows. Aprepitant 125 milligram per hour before the chemotherapy, followed by aprepitant 80 milligram per day orally for 2 days after chemotherapy, rolapitant 180 milligrams or netipitant 300 milligram, and palonosetron 1.5 milligram for one dose 2 hours before the chemotherapy. Adverse effect of these drugs. NK receptors antagonists are well tolerated with a low incidence of the fatigue and dizziness. The drug is metabolized by CYP3A4 and may inhibit the metabolism of the drugs metabolized via the CYP3A4 pathway. We must remember, some chemotherapy drugs are metabolized by CYP3A2, 3A4, including the docetaxel, paclitaxel, etoposide, irinotecan, imatinib, vinblastine, vincristin. Drugs that inhibit CYP3A4 metabolism may significantly increase the plasma level of the aprepitant. For example, ketoconazole, that is the classic inhibitors of the CYP3A4, ketoconazole, ritonavir, navifavir, ribovapamil, and hinidine. Another drugs, antipsychotic, phenothiazine, butyprenorphine, thiazine, benzodiazepine. Severe classes of the antipsychotic can be used for the antiemetic and sedative effect. The antiemetic effect of the phenothiazine is mediated by inhibitions of the dopamine and muscarinic receptors. The sedative effect of the duo of their antihistaminic actions. The most commonly used antiemetic and prochloroprazine, promethazine, and thietylpyrazine. An antiemetic effect of the olanzapine may be due to the inhibitors of the dopamine D2 and serotonin 5-821 and 5-823 receptors. Butyrophenone antipsychotic also have the antiemetic effect due to the central dopamine blocking action. Droperidol, which can be administered intramuscularly or intravenously, is mainly used. In antiemetic dose of the droperidol has a pronounced sedative effect. We can see the drugs from this group. Antipsychotic drugs, previously it was widely used for the treatments of postoperative nausea and vomiting in combinations with the opioids of the benzodiazepine for sedations in the surgical and endoscopic operations, for the neuroleptic anesthesia, and for inductions and maintenance of the general anesthesia. Extrapyramidal effect and hypotensions are possible. Droperidol may prolong the Q2 interval and sometimes provide the pro-arrhythmic effect, and in rare cases cause the fatal episodes on the ventricular tachycardia, including the torsades de points. Therefore, the droperidol should be used in patients with the QT interval prolongations and only in those who don't respond adequately of the alternative medications. Substitute benzamides include metoclopramide and the 3-metabenzamide. The main mechanism of the antiemetic actions is the blockage of the dopamine receptors. 3-metabenzamide also has the weak antihistaminic actions. For the preventions and the treatments of the nausea and vomiting, metoclopramide can be administered orally or intravenously every 6 hours in a relatively high dose of 10 to 20 milligrams. 3-metabenzamide is usually administered orally as a dose of 300 milligrams or intramuscular at dose the 200 milligram. The main side effects of these central dopamine antagonists are extrapyramidal symptoms, restlessness, dystonia, and Parkinsonism. Classic variant of the trimethylbenzamide hydrochloride, 1 milliliter contained the 100 milligram Tigan. The drugs have a mild antiemetic effect, is a stand-alone agents, but are particularly useful in the preventions and treatments of motion sickness. Their use may be limited to dizziness, sedations, confusion, dry mouth, bowel paralysis, and urinary retention. For example, meclizine is an 1,2 antihistaminic drugs with minor anticholinergic activity and sedations. It is used to prevent motion sickness and to treat vertigo caused by mace dysfunction. Hyoscine scopolamine is a prototypical muscarinic receptors antagonism and is one of the best drugs for the prevention of the motion sickness. However, it has a very high incidence of the anticholinergic effect when administered orally or parenterally. The transdermal patch is better tolerated. Superiority over dimenhydronides has not been proven. Hyoscine butyl bromide, 10 milligram in 1 tablets. Benzodiazepines, such as lorazepam or diazepam, are used before the chemotherapy to reduce the vomiting, causing the anticipations of anxiety. Lorazepam, 0.5 milligram in 1 tablets. Cannabinoids. Dropabinol is a A9 tetrahydrocannabidiol, the main psychoactive ingredient in the margiana. When taken orally, the drug is almost completely absorbed but undergoes significant hepatic metabolism. Metabolites are slowly excreted with the feces and the urine over several days or weeks. Due to the availability to more effective drugs, dronabinol is currently rarely used for the prevention of the chemotherapy-induced nausea and vomiting. Dronabinol possible but not popular drugs for the antiemetic effect. Marinol, dropabinol, 2.5 milligram in 1 capsules. Combination therapy with the phenothiazine appear to produce a synergetic antiemetic effect and attenuations with the side effects of both drugs. Autonomic effect results into the tachycardia, conjugations of the hyperemia, orthostatic hypotensions have also been observed. Dronabinol has no significant drug interactions but may enhance the clinical effect of other psychoactive drugs. Thank you for your attention.